Good morning. It's so nice to be back with you. The music that was playing a bit too loud, and for that I apologize, is by a recording artist named Amethyst Kia, recent graduate of Spelman College in Atlanta, and a woman that I heard on a cruise over the course of the past 2 weeks while I was on vacation. This was a recording made for the National Museum of African American History and called Black Myself, and one of the most powerful statements that I know, but also I thought a wonderful way to set the tone for a conversation with one of St. Louis's real treasures, a distinguished scholar and a dear friend and an advocate for the most vulnerable among us, Dr. Will Ross. Will and I have known each other for more years than either of us care to count, and in fact, long before I traded in my attire for black and white, Will and I had a standing pact called The Last Man Standing. Whoever passed away first would donate his bow ties to the other. Neither Will or I plan on doing that anytime soon. Will is the Associate Dean for Diversity at Washington University School of Medicine, also professor of nephrology, taking care of people with kidney disease. Will served early in his career as the medical director and director of ambulatory care services for St. Louis Regional Medical Center, was a founding board member of the St. Louis Regional Health Commission, served as chair of the Missouri Foundation for Health, and the list of his accomplishments and dedication to the needs of those who are most vulnerable among us extends in a quite lengthy way. It's a pleasure to have Will with us this morning. He's a gifted speaker and brings real passion to the work that he does on all of our behalf. And with that, let me introduce Dr. Will Ross to talk with us today about inequities in healthcare and what we as a community of faith might do. Will, welcome.
Okay, is this on? Yes, I can hear it. Great. Well, good morning again. Thank you for the invitation. I'm not used to saying Reverend Smith. I'm just saying Mark. But Reverend Smith and I do go back. We're going to talk about decades. And that just shows you how you can build, I should stay here, how you can build alliances and really have an impact well beyond the initial stage of introduction. And so I just really feel honored to be here and talk about an issue which is very, very dear to me, and that is access to care for all and providing equity for all. I've been doing this for a long time, and there are times when I say, my goodness, we're making progress, and then there are times when I realize how little we've accomplished, and I get frustrated at times, but then I think about the bigger picture, and I have my faith renewed. I want to talk about this bigger picture and this renewal of faith because that really gives me the necessary energy to go on in the face of sometimes overwhelming oppression and overwhelming policies that are introduced at the national level and local level that deter people from reaching their full health potential. The reason this is dear and personal to me because I grew up without access to care, without access to health. I grew up in Memphis, Tennessee in the 60s. And many of you know a lot of things happened in Memphis, Tennessee in the 60s. And I was right there. I was right there at age 10 when Dr. King was assassinated. No more than a couple miles from where I lived. I used to live a couple blocks from the Lorraine Hotel in Memphis, Tennessee. So when Dr. King died, it really caused me to reflect on what I was thinking. I was 10 years old. I was I was a very open-minded, very assertive 10-year-old. And I started thinking, what's going to happen to all of us being African Americans who lived on the fringes, who lived in areas that were disadvantaged and under-resourced? Because I remember when I was 6 years old, my older sister had severe asthma. And one time we had to take her to the emergency room. And actually it was just me and my older sister and my younger sister. We were by ourselves. And I remember 3 misfit kids going to the emergency room at John Gaston Hospital, Memphis, Tennessee. And I want you to think about this picture, okay? You're seeing 3 kids, 5, 7, and 10, poorly dressed, looking pretty much, like street urchins, waltz into the emergency room. And the people were saying, where are your parents? Well, that was an assumption that we all make, right, that we have parents. It's incredible that that's not always true, isn't it? And so I said, well, they're not here. We only have a mother, and she's not around. Our sister's sick. Can you take care of her? And I just remember how we were looked upon. I'll never forget that. It was like we were refuse. We were debris. We were someone, put them aside. I can't believe they're here. This is ridiculous. Treat this girl and get her out the emergency room. That had an impact on me. I was a kid. I didn't know anything about culturally sensitive care. I didn't know anything about health equity. I just felt that we were not being treated right. We were not treated with dignity and respect. And that one instance was seared into my memory. That's when I said, I'm going to be a doctor. And I'm going to do unto others how I want them to do unto me, and not how I was treated back in that emergency room, how my sister, rather, was treated back in the emergency room. And that just got me on this course of really pushing what Dr. King wanted. His focus on having resources available to all. He said of all the injustices, injustice in health is the most inhuman. Not inhumane, he actually said inhuman, subhuman. And so I felt that was really the key. I was fortunate, even though I grew up in some really difficult circumstances. I was fortunate. When I was 15, a Jewish family pretty much took me under their arm and said, well, we're going to introduce you to people in the civil rights movement here, people who were very active nationally, and they said that we're going to get you out of this predicament, but you're going to have to promise us that you're going to stay focused on addressing this issue, on making sure that you spend your whole life on this. Well, that was a big burden to put on someone who was 15 years old, but when I was in a meeting with luminaries such as Benjamin Hooks, who at the time was president of the NAACP, the National NAACP, who was from Memphis. I'm hearing these things, and I'm saying, oh my goodness, I really have to step it up. And so that really was just a historical overview of how I got into this position. Let me just fast forward now a couple of decades. And I'm going through college and medical school here and residency. And then something happened when I was a resident, so I kind of veered away. I kind of retreated into my nerd-like state when I was a medical school and resident. I love science and mathematics and ion channels. I can do that stuff all day. That's what I do naturally. I get into a closet, I get into a corner somewhere, and I take out my science, math, and books, and I'm happy. But something happened that woke me up. I guess that's the new term, woke. I've always been wanting to use that term, woke. I'm trying to weave it into my normal parlance. I'm always about to kind of step behind, the millennial kids, and so something that woke me up. I was a resident at Vanderbilt, and I was in my 3rd year at Vanderbilt Medical Center. And it was a cold December. Someone walked into the emergency room, 60-year-old white male. And the nurse called me over and says, we need to see him quickly. He has a fever of 105. His knee is really inflamed. This guy really is in bad state. So I walked over to him. I said, sir, let me look at your knee. It looks like you have a huge infection. The knee was like really massively swollen. And in all likelihood, he had what we call septic arthritis. He had a just a massive infection in his knee. And I said, sir, I'm going to have to take a needle and insert it into your joint space and remove that pus, all that purulent material. Then we have to put you in the hospital. He looked at me and he said, with all due respect, I'm going to have to find another doctor because I don't want anybody like you taking care of me. And he called me the N-word. And that hit me like a ton of bricks. I mean, I had grown up in Memphis, Tennessee, okay? I had seen and I had experienced racism, but I wasn't prepared for that. I wasn't emotionally prepared for that. I just didn't expect it. But then it was my moment. We all have our moments, right? We all say what we believe. We say what we think we'll do under circumstances. But every once in a while, when we're put in those positions to act, do we have actions that mirror our belief systems? And so that was an opportunity for me to say, who am I? What do I truly believe in? How do I respond to this? Because this is really part of this issue of how we see each other in this country. And it translates into who gets care, health care, who doesn't get health care. And so I said, I thought about what I learned in Memphis from Benjamin Hooks and Francine Hooks and the Wexners about Dr. King's philosophy of true love, of reaching beyond boundaries. I said, sir, my name is Dr. Will Ross. I'm your doctor. You're not going to have another doctor. You have a couple of options. You can allow me to treat you, or you can leave the emergency room. And I don't think you want to leave the emergency room because you're in pretty bad shape. But before I treat you, you're going to have to apologize. So what's it going to be? There was this awkward silence. He's contemplating things. You know, I'm sure he's been socialized to thinking certain ways for decades. And so he's thinking this through, and he said, I probably shouldn't have said that. I probably shouldn't have called you that. I don't hang around people like you a lot, and I'm sorry. I said, apology accepted. I'm going to treat you with the utmost dignity and respect the way I would treat anybody else. That was my opportunity to say that, okay, I really get this. I get what they were telling me when I was 5 and 10 about elevating this discussion. So with that, I think that I really became much more focused and disciplined on what needed to do. And when I went on to do my fellowship training in nephrology, I had another opportunity to really start thinking about things on a larger scale. So I was giving a talk in Washington, D.C. I wasn't supposed to give this talk. My lab mentor, Dr. Aubrey Morrison, was supposed to give this talk, but he was out of town. He says, Will, can you go give this talk for me in Washington, D.C.? Rule number 1, chance favors the prepared mind. Always prepared. You never know what's going to happen. So I went on to give this talk in D.C., and I was talking about something really basic science and geeky stuff, ion channels. The talk was sponsored by the Surgeon General at the time. Her name was Antonia Novella. She was the first Latina Surgeon General. And after the talk, she says, Will, I understand that you like all this science and ion channel stuff, but we need people to think about this at a larger scale. I need somebody to start thinking about health policy. I need some help. Can you really shift your gears and help me out here? She was asking me to step away from all the things that I wanted to do intellectually. She said, step out of your familiar, and walk away and think about the larger issue here. That was tough, because I had every intention of being a basic scientist like my lab mentor, Aubrey Morrison. But she was saying, please think bigger. Think about this issue of health policy and health access, and people are going to benefit from this. And so I did. I went back to Washington University and I announced I was leaving the laboratory and I was going to take this focus on addressing health policy and health equity. And they said, Will, you're destroying your career. How can you do this? I said, destroying my career? I mean, we have, I mean, there are people who can't come and see us at Barnes Hospital and George Hospital because they don't have access to health care. There are people who are dying, and we have infant mortality rates in certain zip codes that are 3 times that of Bangladesh, underdeveloped country. We have women who are dying of childbirth in this neighborhood. We have African Americans and Latinos who are more likely to develop high blood pressure, twice as more likely to develop high blood pressure, twice as likely to develop diabetes, more likely to develop eye complications, kidney disease, the need for transplantation. This is happening within a stone's throw of here. We have all these resources here, and we're not really diffusing our intellectual largesse and our social justice mission into the community. And you're saying that I'm going to jeopardize my career? I said, if that's the case, so be it. At the time, the dean was Dr. Bill Peck, William Peck, a wonderful guy, but he just thought that I was making the wrong move. He said something, Will, if you're going to do this, here's what I want you to do. We have this public hospital here, and I think you can go there, and as a faculty member, you can still do some clinical research, but you can do some things with the community. That's where I really started to pivot even more so. Let me tell you another story, then I'm going to go on about, because I really want to engage you. So I'm here at this hospital, St. Louis Regional Medical Center. It's not too far, it's on Delmar, right across from Delmar, right across from Union, from Euclid. And so I'm there, and I don't know how many of you are from St. Louis, but we went through a really difficult time in 1979 when one of the largest African American hospitals closed, Homer G. Phillips Hospital. Some of you may know that story. That's a whole separate discussion because I'm doing a book with a colleague of mine on that. That's a whole separate discussion on what happened there. But we were seeing history repeat itself when this hospital was also destined to close. And although I tried to do my part to keep the hospital open, the city just simply decided to close it, and we were unfortunate that it closed. But something happened. As I'm leaving this hospital, having fought to improve health care in North St. Louis, North County, for African Americans and other underserved individuals, having spent years doing this, which I hadn't intended, I didn't realize I had to go back to the medical school. But when I was walking out the door, one of my patients, former patients, B, I remember her name, she was sitting there at the front door. And I walked back, and she grabbed me by my hand, like this. And she grabbed me really tight. And she says, Will, she says, Dr. Ross, don't forget about us. I said, I won't. And I tried to go away. She did not let me go. She says, do not forget about us. I said, I'm not going to forget about you. And she said, do you hear me? Do you hear me? She says, do not forget about us. And my goodness, I didn't realize what she was saying. Sometimes you just have to just step back and listen to people. Okay? You have to truly hear them. You have to connect with them on a higher plane. You have to let what your preconceived notions of people are saying flow out the door and listen to them. What she was telling me was, okay, thank you for helping us here, and you're about to go back to this Mecca, but we're still here. We're still here. And we don't feel comfortable going over to your Mecca because you don't treat us with dignity and respect at times. Because when we're over there in your Mecca and we're in your hospital, you walk by and you don't give us pain medications the way you give other people pain medications. You don't give us surgery the way you give other people surgery. You walk by us, and it's not just black people. I'm talking about people who are living on the fringes, particularly low-income people. She's saying that sometimes you forget about us. And hers was a reminder. She says, please don't forget about us. And I just sat there, and I'm still living this moment now, still living this moment of what this woman was saying to me. And I just remember, I just felt this, I was just overwhelmed with emotion. And I could just feel the tears coming down because I was thinking about how I grew up and what I was told when I was 5 and 10 and 15 about doing something larger, something greater. And I said that I'm not going to forget about her. And so I really just simply decided that my life after that really is going to be focused on issues of social justice and trying to do the things that Reverend Smith and others are doing here, trying to really connect us to a larger mission. And that larger mission for me really is saying who has access to resources in this country, why do we have this divide creating haves and have-nots, and the most important thing for us is that what's the next stage, what's the next step? So I decided, in the past 25 years, to really just start talking a little bit more about that and writing about that, about what is the next step, because I could easily sit in my office and write about health equity and write about the fact that we had until 2010 55 million Americans who were uninsured. I could write about that. I could write about issues of people who were paying, who couldn't afford their premiums. I could write about that. I could write about people who are not accessing health care because they can't afford the prescription medications. I could write about that, or I could talk about people who had social and structural barriers that prevented them from accessing care, that I have physicians and medical students I teach, and they say, my goodness, Dr. Ross, this patient missed 3 appointments. She won't come to see us. And when she comes, she's in a bad mood. I mean, she's non-compliant. Well, I mean, why are you spending so much time with her? I could write about that bias that we have in medicine, how because of our own problems, we label the patient as being non-compliant, and we fail to step back and say, what is going on? What are those social and structural barriers? What are the social determinants of health that prevent people from accessing care? And predominantly, we know that I can, as a kidney specialist, I can put patients on dialysis. I can put them in, on a track to get a kidney transplant. But I can't always address the issues, the real root issues in their lives. How long does it take to get 2 buses from North City to get to my office? Why should I assume they even have the bus fare to get to my office? What happens when they have a child? Who's going to provide child care when they're trying to get to my office? What happens when someone dies in their family and they don't have time to grieve and then they have to come to our office? What happens if, because of the structural problems we have in the educational system here, where in St. Louis City, a black individual, black kid who graduates from 12th grade has a reading comprehension of an 8th grader in the county? So what happens when someone graduates because of structural barriers in how we deliver education system, that people have low levels of literacy, and as a consequence, they don't understand what I'm saying even if they are there. And we don't take the time to really break it down to them. What happens when we have these structural and social barriers, and we in the health profession are doing very little to dismantle those barriers, and we put the blame on the patient? What happens? That simply perpetuates all these inequities, and we in the medical profession are complicit if we don't start stepping up, taking a moral stance, and saying that we are going to do what we can to eliminate social and structural determinants, structural barriers to health. So that's so I started thinking about all those who are labeled non-compliant, and I started thinking about all that bias that circulates in the medical profession about how we see people, and how it can't be anything with us; it has to be them. And I said, oh my goodness, we have to restructure our whole curriculum at Washington University. We have to start really teaching our students and our trainees how to deliver compassionate care. We have to get them into the community. And that's been part of what I'm doing, trying to really, and that's taking a whole new light, thank goodness. But most importantly, and here's where I want to just kind of stop and I want to engage us on some solutions. What do we do now then to once we're aware of all these social structure barriers, what do we need to do now actively to re-engage laity, to re-engage the professoriate, to re-engage professionals on this quest to really get back our country, get back our dignity, get back the respect that all patients should have. That's where we are right now. So, so these are difficult times, and I'm not going to pretend that I know how to do this. I've been in and out of D.C. For many years, particularly around the Affordable Care Act, when I was working on building a way of having people access health care through a public option, trying to create competition in the healthcare system. And I just remember all that time I spent up there in D.C., and I said that at least we're getting somewhere. And it happened when we passed the Affordable Care Act under President Obama, and we insured 35 million more Americans. But we're not where we need to be. And it's because of something much more simple. We in this room understand compassion and dignity and respect. We all get it. This is a very enlightened group. But for some reason, when we walk out of this room, we've unfortunately just entered this horrible stage of tribalism where people don't have that type of understanding. And I've been trying my best to say, what do I do to address health equity? How do I address these questions that Reverend Smith put to me about bias in medicine and trusting physicians, and what do communities of faith do? What do I do? And I've concluded that we have to start doing what I did in that emergency room in Nashville, Tennessee in 1986. We have to start talking about our moral obligations, much more so, as we try to advance health. We talk about what's good in terms of reducing healthcare expenditures. In fact, we spend $3.5 trillion in health, and we should reduce healthcare expenditures. We can talk about that, but that's not sufficient to drive this. We can talk about health equity, getting everyone their full health potential. But some people don't understand that either. They say, well, you know what? Some people just put themselves in that position. I've concluded that I don't have to start talking about moral obligations. I'm fortunate to announce that in March I'm going to receive an honor at the medical school, a professorship. And I decided that I'm going to put Washington University, I'm going to challenge them to really step back as an institution and say, are we willing to say that we have a moral obligation to advance health equity? Can we use that term? It's going to be provocative, but that's the term that we've fallen away from for reasons that I think that we think that, I don't know why, but we've fallen away from that. So I'm hoping that I can reinfuse this larger principle, because I think that's the only thing that's going to really be able to resonate among a larger diaspora of people. So I've given you a sense of where I came from. I've seen the massive array of indignities imposed on people of color, low-income people, people disenfranchised, people in the LGBTQ community. I've seen these things. I've tried different approaches, and year after year, I see nothing changing. It's been flat for so long that I said that I have to go back to the basics. And for me, the basics were going back to my roots in Memphis, Tennessee, and learning about the civil rights and learning about moral valuations and the need to really use King's philosophy to really push for a moral stance and to infuse social justice in communities of faith and communities of medicine and our family communities. That's my approach going forward. I need your help because this is hard. I falter. I come here to be invigorated. I need your energy because when I get out there and do these things, I sometimes feel tired. And I've been doing this for a while, and I sometimes feel like I'm not making any traction. But when I come into communities of faith, you all remind me, that you cite these things to me about being patient and being long-suffering. And so I'm here to gain more from you than you can ever gain from me. So I want to thank you for giving me this opportunity to come and share my story and my charge to all of us. And now let's stop. Now let's just have some discussions. I know we have about 10, 15 minutes to 10, 15, close to 10, 15, but there are some opportunities to talk about some questions that were posed to me. So let's stop there and just ask for questions. Yes.
So I was thinking about your talk about. Let's pause for a second. What we'll do now is we'll go to our tables and talk first, and then we'll do Q&A. So let's spend 10 minutes. You have questions on your tables about have you experienced bias in attempting to access healthcare services? If so, how? Do you trust physicians, hospitals, and other healthcare providers to be honest brokers of medical information and advocates solely for your best interests? Why or why not? And then what might communities of faith do to advance greater equity in healthcare locally, statewide, and nationally? We'll talk at our tables for 10 minutes, then we'll come back for question and answer with Dr. Rouse.
I appreciate it, but it's just...
positions on that view?
I will, oh, and then very, very high.
Yep. Let's put them under chairs instead of on the view.
How are you? Hey, we blew the budget. I'll slip you a coin. It's so hard, and I think LLC would agree. Like, you don't know what stuff costs. You like pick 333 or whatever. Yeah. And then they get there, it's like 73 bucks. Oh man. Yeah. Anyway, how did it go yesterday for you guys? It went all right?
Yeah. No, I mean, so, you asked is Oscar for us to be one of the partners.
Oh, yeah, that is weird. Hi. Woo. Yay!
Good landing. That's the landing.
Something you need to learn. You do not go, uh-oh. Yeah.
Yay!
So they know that, like, nothing's okay. Yeah, you need to learn.
Oh, that's the yoga pose right there. Can you help?
Man, he is mobile. That is awesome. What? How he's... Oh, that's cool. You know what? We had fun doing it. We had, like, mother-son time. So you were missed, but we made the best of it.
As you do this, if you notice any of the labels,
I'm liking it too. We had to. It was nice the other morning, animals.
Yeah.
Space operating.
But it was all, it also just like people congregating for it, really gross as they got.
Yes. I forgot about that.
So then it comes to these days, like, no, you can't sit here. These are all reserved. Oh, look.
I forgot about that. All right, I'm gonna go back in. I realized I left my coffee in the car. Are you helping? Only things.
Not really.
You helping?
He's crying.
Uh-huh.
I gotta move that. Yeah, can you go back?
Yay.
Come on, get off. You look at Papa.
You try that program with it. I thought that time.
The other thing to do.
Take the envelopes out. Festival of Flowers and Music offering. Take that out. What do you think? Yeah, we don't need to throw them away. Right. What are you doing? 2 per, or 1, or what? Yeah, let's just do 2. 2 per slide, 2 per pew. Why don't we just do 2 per slide? Got it.
Speaking of renal division, I talk with Alan Robson every couple of months. weeks ago. She was in town.
I remember it was Barbara Cole who decided that the pediatric renal division needed an armchair psychologist. Alan and Rob said, why? We don't need that. That's what we do. Barbara said, you may think you do it, but you don't, so we're going to hire Mark.
We're going to get started with questions, if you don't mind turning your mic back on. And I'll do a little intro and then ask the first question and let people do mic stuff. We're still getting used to having the speaker system in here, but it really helps
sure.
some of the folks. So.
Do you want to take them through the questions that were table questions, or let them ask them?
Let's let them. If you want to take them through table questions, why don't you do that?
Yeah.
And then I'll lead with question and answer afterwards.
Okay.
All right. So gather people back together.
You say we have until 10:15, right?
Yeah.
Okay.
10:15. So
Okay.
I'm going to take about 5 minutes on table questions and then turn it over.
Yep.
Okay.
Hello, everyone. Can we come back together? What we'd like to do is to take the next 5 minutes or so and just touch on your response to any or all of the 3 questions that were included at the table, and then wrap up with some open-ended conversation with Dr. Ross. So,
And I would ask you, if you do want to share something, please let us hand you a microphone. We do have some folks who are using assistive hearing devices, and if that would be ever helpful for you hearing in here, the assistive hearing devices we use in the church do work in here, so please give us the second to pass you a microphone so that folks can hear you.
So the first question, have you personally or members of your family experienced bias in attempting to access health care? And if so, what did it look like and what did you do about it?
It was interesting. At our table, we had stories of bias in a, I guess, positive way, where we were treated better than others because of hierarchy. One in a military setting, one because the patient, me, was a lawyer, and the doctors figured that out and gave extra treatment, but it was very obvious. We talked about family members who were clearly immigrants, who were on public assistance, who did not get, who were treated less fairly, or certainly didn't get the same kind of treatment that, you know, the lawyer or the high-ranking military person got, until someone else came in and advocated on their behalf. And we talked about, your point was so excellent, I wish you would make it, about the dynamic.
I was just saying that the unfortunate thing that happens in these hierarchical situations is that the person who is the weaker starts to take on that role themselves and expect to get second-class kind of treatment, and it's sort of the loop then gets reinforced that I shouldn't be in this front line, I don't have money or whatever, and I'm second-class, so.
So I'm seeing a number of heads nod around the room, which suggests to me that perhaps the second question is equally important. Do you actually trust doctors and hospitals to be your advocates and to be the honest brokers of information?
Well, we were talking about we trust the doctors that know us, that know our history, and Diane and Elizabeth were both saying they would go to a doctor that knew their history and, you know, didn't make assumptions about them.
Yeah, our table had much the same response as yours. And I think that, yeah, we were saying that you trust your individual doctor, but you don't trust the system because it's infused with profit, the desire for profit. So and the other thing we talked about is that it's a problem on both sides of the stethoscope, you know, that doctors are so defeated, oftentimes young doctors, and there's so much depression because the system is an obstacle to true care. And the other thing we talked about is the paradox that, you know, up until really recently, most medical care didn't work. now that it does work, oftentimes people don't believe it. So, yeah, there was general distrust of the entire system.
So perhaps to the third question, what might we do about it? As a community of faith, or as Shirley leads in our conversations, as a beloved community, what's our role?
We jumped right to this question because nationally we've been hearing a lot about this idea of Medicare for all or Medicare for all who want it, and we're wondering, especially your opinion, if that's something as a community of faith we ought to be advocating. And also we talked a lot about the role of profit in healthcare and how we believe that it's inappropriate, it's morally inappropriate.
Any other comments before we open it up for general questions? Randall?
Thank you. Well, on this topic of what can we do as communities of faith, I'll draw on the work of Robert Cloninger at the Center for Wellbeing within the Department of Psychiatry at Washington University. To me, it comes down to outlook. If we're able to develop that sense that we're all in this together, Cloninger's term self-transcendence, but that awareness of unity, if we're able to develop that, that's the antidote to tribalism.
Good point. Let's open this up now to general questions from all of us. What an incredible resource we have with us today in Dr. Ross. Mike, the first question.
I'm going to take privilege of first question. There's been a lot said in theological circles, which I'm a lot more familiar with than medical literature, but around the, and sometimes it's phrased as burden, sometimes it's phrased as privilege, but that people of color who are in an academic field feel that they have to carry the questions of social location, and that, you know, black theologians, all of their theology gets labeled black, whether they are, you know, and gets removed from sort of the default. One of the things I'm aware of is in the medical field, there are serious questions being raised and new studies about the way in which we norm how certain bodies work. New studies that show that because we have normed the way that male reproductive systems work, we have fallen behind in our understanding of how the female reproductive system works, and it's affected how we practice medicine. I wonder if you could talk about ways in which the medical profession is trying to move away from sort of cisgender, heteronormative, white normative ways of thinking of the body that have paid off in medical outcomes.
Yeah, I appreciate that. And again, it's just remarkable as physicians, as a medical profession, we're not immune to bias. And it's amazing what stereotypes get perpetuated in the medical literature. Let me just real briefly, an article was published in JAMA about 5-6 years ago, looking at a sort of core beliefs that medical students hold and that residents hold. And all these core they asked 20 questions, and all 20 questions were false. You know, blacks have thicker skin. Blacks are less tolerant to pain. And went on and on. All those were false, but 50% of medical students still held those beliefs to be positive, true. They're ingrained in how we think. That was a really frightening concept, you know, in that JAMA article. And so, you know, I'm thinking that, you know, how do you go back and deconstruct those arguments so that you can actually have an opportunity to bring in, you know, that, you know, a truism. And it, you know, I can't take all the physicians in America and put them back in the classroom, but they need to be. There was this a movie back in the 80s called The Drop Zone, where African Americans who didn't understand hip culture were dropped into this room where they were, you know, bombarded with information so they could become hip. So I think that, so it's a really cool movie if you haven't seen it. It's called The Drop Zone. So I think that all these physicians need to be dropped because they are all operating with this incredible bias, and it's just simply affecting how we treat our patients with this, you know, you're right, this heteronormative belief system. it means that we have to go back into the classroom, the things that, a lot of people here, Amanda and others, are working on to get to the core belief of what our students believe in, put them in simulated settings where they can have model patients who can question their belief system, and then talk it through with their colleagues in a manner that'll be kind of open-ended. That's how you get to that. That's going to take a lot of time, but we have to just go back to ground zero. Do you agree?
I'm an emergency physician at Barnes, and I've worked a little bit with Dr. Ross in some of the curriculum development that we're doing at WashU. And some of the kind of shining lights, I think, are that as the medical field, as the people on this side of it get more diverse, that is helping. There have been, a lot of studies into bias, and I think particularly women of color tend to have just globally the least implicit bias when you do testing on that. And we're getting more people, of different backgrounds into medicine, which is helping. But it is challenging, and I'm very curious to kind of listen to how people respond to some of these questions. Because for me, I work in emergency medicine. By definition, like, you don't know me when you come in. Like, I don't have any, I don't have a long-term relationship with most of my patients. Some of them we get to know really well, but most of them we don't know. And so this is something that I think about a lot: is how can I, in a very brief period of time, figure out what I need to know to help take care of somebody, and for them to trust that I have their best interest at heart, and how can I be aware of that? Because when you have limited time, you do rely on just your snap judgments and your quick thinking, and sometimes that is coming from a place of bias, even though you don't realize it. And so it's something that we have to try. Like, we actually in emergency medicine, because of our time limitations, think a lot about is how do we be careful that these things aren't happening. Like, I'll literally sometimes sit back and say, if this person was X, Y, and Z, would I or would I not give them pain medication? And if the answer is yes, no matter who it was, I would or would not give them pain medication, then you go with that. But it is difficult to do. But I do think that there are some, positive things going on, and the fact that we're having these deliberate conversations too, I think is very helpful.
Yeah.
Other
Yes.
questions?
What can we do?
So-
This community. I don't think I heard an answer to that question.
So great. I was going to interject. So someone mentioned about Medicare for all, and what can we do? We have to realize that we in the faith community have an obligation to provide care to everyone. That we don't operate on what's practical or what's convenient. We have this belief that health care is a right. It's not a privilege, and that every American should have access to that. We believe in health equity. That is, every American should be able to reach their full health potential. And that means that we have to have a healthcare system that provides that. Now, that's a fundamental change in our philosophy about healthcare delivery, but we need fundamental change. Where am I on this position? I'm a big believer in having a complete restructuring of our healthcare system and access for all. I recognize that that's not always politically expedient. And so I found myself really supporting President Obama with the Affordable Care Act. I said, that's better than nothing. We can get 50 million people insured. And so I think that, so I'm still in that approach. I think that we try to find some incremental way of getting ourselves through this with the long-term vision of having a Medicare for all. I'm all over that. In the short term, we look about what we can do here locally, and many of us are aware that there is a referendum in the state to expand Medicaid. We're one of 13 states that haven't expanded Medicaid. We had a referendum that passed in Nebraska, Idaho, and Utah, where the public went to the ballot box, irrespective of their politicians, and they pushed for Medicaid expansion. That was the dictatorship of the proletariat. People out using their voices. We can do the same here in Missouri. The polls show that this could work, but we have to believe that we can push this through. This is going to be a big issue. It's on the ballot for November 2020. I think every faith community, every person who really believes in healthcare as a right needs to be out pushing this Medicaid referendum. Absolutely.
We have time for one more quick question. Does anyone want to offer?
Okay, so not seeing a question, I'm going to take one more moment of saying, one of the things in that last question about what a community faith can do, there's all sorts of questions about nationally, but I just want to recognize that this is a community of faith that has been doing this work for generations. From Dr. Homer Nash to Dr. Allison Nash, who have been leading Black pediatricians in our city, from all the way to folks like some of the folks in our pastoral care committee that have showed up at hospitals. If you find yourself in the hospital and feeling alone and wanting some health advocacy, don't hesitate to reach out to your church. There are folks in this congregation who have provided big-time help getting a second opinion or helping folks find a place to do rehab. This is a place where people have showed up for each other in questions of healthcare on a personal level in ways that, frankly, as a priest, I'm astounded by. The resources and depth of care in this congregation really, really surprised me, and not least in that is having Mark Smith with us, who knows our healthcare system in St. Louis inside and outside and has been a huge resource. So you can do things on the local level, and if you need resources, please don't hesitate to reach out to us as a congregation. And I do want to remark that we have some incredible docs and nurses and social workers and folks who are fighting this fight on the ground every week at Holy Communion, and to say thank you to all of them as well. Next week, we are going to have a couple of leaders from Metropolitan Congregations United, and specifically their work on the school-to-prison pipeline. One of the other places of systemic inequity that we're talking about during this Black History Month is the way in which schools are becoming a place where arrest records begin, especially for children of color. MCU is working to push back against that and are going to invite us into that work. So don't miss that next week. Will you join me in thanking the Reverend Dr. Mark Smith and Dr. Will Ross?
Thank you. I don't often get to do this, but I'm going to indulge in the prerogative of the priest associate and ask Dr. Will Ross if he'll consider making his remarks when he receives the endowed chair available to Holy Communion, that we might share those remarks with the larger community.
I most certainly will. I will deliver the speech directly to you.
Thank you, Will. Again, please join me in thanking one of our real gifts, Dr. Will Ross.